So I'm Peter Kunzman, Head of Research and Policy at Action on Hearing Loss. So who are we? Well, Action on Hearing Loss was formerly known as RNID, but it's the largest charity for people with hearing loss in the UK. And we work in a range of ways, including, but not limited to, direct service provision. For example, we provide hearing aid maintenance services. We also fund biomedical research. We conduct research into the barriers that people with hearing loss face in a range of ways. This can be in terms of sort of their barriers to employment, or getting hearing aids themselves, or just, for example, accessing the doctor's surgery, whether or not they're going there for their hearing aids or not. And we also campaign and try to influence government. So why are we interested in the link between hearing loss and dementia? Well, first of all, it could have huge implications for the people we represent. If there is a causal link between hearing loss and dementia, this is something we really think people with hearing loss need to know. Also, although we think the argument is already incredibly strong for the government and the NHS to take action on hearing loss, to avoid the pun there, we also think if the link between hearing loss and dementia was sort of properly proven, then that would considerably increase how much we can influence government. It would, I think, really focus minds amongst policymakers. So as background, why is all this important? Well, our figures suggest 11 million people in the UK have some level of hearing loss. And of those, 6.7 million hearing aids would be an effective intervention for. We know there is considerable evidence, and this has been accepted by NICE, the National Institute for Health and Care Excellence, that hearing aids improve people's quality of life and ability to communicate. Unfortunately, of those with aidable hearing loss, only around 40% of people actually have hearing aids. And I realise this differs slightly from the Eurotrack study, but there are certain methodological differences between those two. But for our purposes, we use the 40% one. So why is this gap? Well, there's a range of reasons. The biggest gap between the number of people who have hearing loss and the people who end up with hearing aids, the biggest stage they drop out, is when people don't actually seek help to begin with. Now, this could be due to a range of factors. Just embarrassment is one. Another one is failure to even recognise they have hearing loss. One thing we frequently hear is people saying, actually, it's just other people who mumble. It's not me who actually has the problem. The next biggest stage where people drop out of the system is when they go to their GP, and the GP actually doesn't refer on. And there is a certain amount of work we're doing on that front already. And then there's also, once people get to an audiology department, there are problems there too. There's certain instances of rationing going on, and sometimes this is implicit or explicit. One of the explicit one is actually in North Staffordshire, where it's an area of the UK where they've actually stopped giving free hearing aids on the NHS to people with only mild hearing loss. And that's something we are strongly campaigning against. That's one of the more obvious examples. Some of the examples are slightly less obvious, where, for example, an area of the country, a health area, just doesn't fund the hearing aid services or not. There's no official policy not to give hearing aids, but some areas do have quite low access rates. Now, fortunately, everything I've mentioned is amenable to policy change. In terms of sort of the embarrassment, people's failure to recognise hearing loss, all the factors like that, perhaps public awareness campaigns could do something about it, either that come direct from the charity sector or that are funded by bodies such as Public Health England. Another kind of way into it is running screening programmes. We have advocated in the past a universal hearing screening programme across the UK. Not that it ultimately resulted on one, but it's something we believe in. And also going back into the GP surgeries where I mentioned earlier on, they often don't refer on, better training for GPs, and that is something we are actively working on now. And there's also increased capacity in audiology departments. As I said earlier, sometimes there are policies in audiology to restrict people, sometimes they're just not getting enough money. So all these things could be sorted, but this is not the very top of the government's agenda. There are certain things, sort of the national plan, the action plan on hearing loss, but although it is important, we can't say it's very top of what the government is thinking about right at the moment. So where does dementia come into all this? Well, we know dementia costs society a huge amount. As Paul said earlier on, the cost is estimated to be around 26 billion per year. Now, a large part of this, about 17.4 billion, is paid privately. However, there's still huge costs to the state. The NHS picks up around 4.3 billion of the costs, and local authority care services around 4.5 billion. So the state is paying a huge amount on this, and therefore if something could be done about it to reduce those costs, that is something that could focus the minds of policymakers. So what do we know? Well, people far more expert in this than me have presented already. But we know hearing loss is associated with dementia. We know mild to moderate hearing loss is associated with approximately double the risk of dementia, severe hearing loss with 5 times the risk. And we know from longitudinal evidence that hearing aids appear to slow the rate of cognitive decline. But the link is not fully accepted as causal. Unhelpfully in the, there is NICE guidance that was published on hearing loss last year, which is great in many respects. However, it does sort of point out that they don't accept that the link is causal. So what are we doing? Well, we are very interested in this, and so we are funding some research on the subject, jointly with Alzheimer's Research UK. And this is research that will hopefully commence at the University of Manchester later this year. So a lot of this has been talked about already, but there are other data sources that haven't been fully exploited yet. There's the UK Biodata Bank. One that I'm more familiar with is the English Longitudinal Study of Aging. Huge longitudinal study in the UK, tracking people over the age of 50. And one of the useful things that happened in that study was not only did they ask about aspects of people's sort of cognitive abilities, but they also gave people an objective hearing screen. They used a handheld screener to detect their level of hearing loss. So that is something very important about that data set. So what we are looking to do in this research, or what we're looking to fund this research to do, is really explore dig more deeply into the nature of this link. Is it a causal link? Is it part causal? Or is it due to common causes? And if it is causal, what are the mediating factors? Is this working through depression, social isolation, for example? Now, we think all this will help a lot. However, probably what in the longer term is really going to focus minds is a randomized controlled trial or a multitude of randomized controlled trials. So that's really all I have to say on the subject. I think other people will be able to say a lot more detail than that, but there is our perspective.